Hi, my name is Scott Smith. I'm a consultant with the Center for Behavioral Health and Justice. Today's training is targeted specifically to community mental health and community mental health contracted clinicians to help you know all that you'll need to know in order to determine whether a client is appropriate for assisted outpatient treatment, what the benefits might be, and how to start the process of obtaining assisted outpatient treatment orders. When we're talking about why AOT may be helpful, we want to consider who is really eligible for assisted outpatient treatment. And then according to the law in Michigan, AOT is available to adults who have either a serious mental illness or a developmental disability, but don't understand that they need treatment due to impaired judgment as a result of their illness, a condition some call anosognosia. Those individuals who are unlikely to voluntarily participate in or adhere with treatment to keep them from harm. They have a mental illness, not exclusively a substance use disorder, and not dementia, including Alzheimer's. And those individuals who, without treatment, are likely to deteriorate, resulting in harm to themselves or others. Why utilize assisted outpatient treatment? We know that individuals living with a serious mental illness are more likely than others living with a mental illness to not seek treatment, to not adhere with existing treatment, to function independently far less often. That is, they may live with family well into adulthood. They might require supervised living in a adult foster care / group home setting. We also know that they're more likely to avoid those who point out that they're ill, which often results in having poor social support. And finally, they're more likely to not recognize that they have an illness at all. Additionally, we know that untreated serious mental illness is a significant contributor to increased rates of suicidal and self-harming behaviors, violent behaviors, homelessness, and housing insecurity, to high rates of utilization of emergency rooms and inpatient psychiatric hospitalizations, and to high rates of contact with law enforcement. What issues can AOT help clinicians address? There are many reasons why individuals living with a serious mental illness do not treat their illness, and assisted outpatient treatment is especially well suited to address the following: poor access to care, housing instability, co-occurring substance use disorders, paranoia related to treatment, for example, beliefs that the meds they take are poison or that the providers want to hurt them, and anosognosia, that is the impairment in the ability to recognize one's illness. One of the issues that assisted outpatient treatment can help clinicians address is anosognosia. As we've mentioned earlier, this is the impairment in the ability for one to recognize that they're ill. Historically, it's been recognized as occurring in stroke patients and individuals with dementia. There's increased evidence that it may also be a factor among individuals living with a serious mental illness. It's been included as a symptom of schizophrenia, beginning with the DSM for text revision. And it's important to note that we're still learning a lot about the brain and about related conditions. And so there is some debate, and it's reflected in the way that it's presented in the DSM, using the language comparable to anosognosia. Multiple studies have found that individuals living with a serious mental illness very often experience anosognosia or anosognosia-like behaviors. Between 50 and 98% of individuals living with schizophrenia, for example, have been found to experience this impairment in the ability to recognize that they're ill. And around 40% of individuals living with bipolar disorder. This is especially true of individuals with bipolar type 1 when they're in a hypomanic or a manic phase of their illness. In recent years, we've developed a better understanding of what might be happening neurologically to someone experiencing anosognosia. And the damage seems to be located in a few different regions of the brain. First off, the frontal lobe, which is responsible for our body movements, for thinking, feeling, imagining, decision-making. And a very small portion of this frontal lobe, referred to as the prefrontal cortex, is responsible for those highest order activities that we do: decision-making, judgment, planning, regulating emotions, and impulse control. This is the last part of our brain to develop as adults and typically isn't in place until our mid-20s. Now, additionally, we know that there seems to be parietal lobe involvement, which is the part of the brain where we're able to recognize and integrate information we get from our senses. That is what we see, hear, smell, taste, touch. And it's especially important in processing the stimuli we receive via touch. So things such as pressure, pain, heat and cold, all are really processed and integrated in this region of the brain. And if this area of the brain were to be impaired in some way, we might see individuals who experience a heightened sense of some of these sensations, such as enhanced pressure or pain, or an insensitivity even to things like heat and cold, something that might help explain what we notice about individuals who are experiencing some type of homelessness, who are often out in very adverse weather conditions. They seem to not recognize it as much, and sadly, in some instances, they die of exposure, potentially because they don't recognize the extent of it, in addition to all the other social causes. Another part of the brain that has been implicated in anosognosia is the insula. And this region of our brain is responsible for very high-level functions, including how we form emotional reactions, such as anger, how we evaluate the intensity of pain. And there's some evidence now to suggest it might be this part of the brain that is damaged and linked to opioid use disorder. The insula is also responsible for risky decision-making, specifically about our ability to defer making decisions when we're highly emotional. Damage to the insula seems to be consistent with individuals who make decisions in highly emotional states more often than those who don't. It's responsible for the formation of social emotions, such as sympathy, and it plays a key role in interoception, that is, our awareness of self, the perception of sensation within our bodies. Now that we've discussed what AOT can help you do as a clinician for your clients, I want to talk about the benefits of assisted outpatient treatment. There are many services that can be ordered in an assisted outpatient treatment order. These include case management, medication, often via long-acting injectable formularies, lab tests to determine medication adherence, efficacy, outpatient therapy, individual and/or group, day or partial day programs, educational or vocational training, supervised living, assertive community treatment, substance use disorder testing and/or treatment, and other services at the court's discretion that, as the legislation puts it, can prevent relapse or deterioration of the individual's mental health. Now, I do want to note that substance use disorder testing and treatment can be ordered via assisted outpatient treatment. And while a substance use disorder is not grounds in and of itself to get an assisted outpatient treatment order, for those individuals with co-occurring disorders, it is absolutely possible to have substance use disorder treatment testing part of their assisted outpatient treatment order. And the court will rely heavily on you as clinicians for the recommendations of the services that would be most appropriate for your client. Of the states with assisted outpatient treatment laws, New York is one of the most studied. In the studies, the average individual receiving assisted outpatient treatment shared the following characteristics. About 71% were diagnosed with a psychotic disorder. On average, they had 3 inpatient psychiatric hospitalizations in the previous 6 months prior to the AOT starting. They were not adhering to psychotropic medications. That was true for about half of them. About half also had a co-occurring substance use disorder. 30% had been arrested, and about 23% had been incarcerated. And nearly 1 in 5 had experienced recent homelessness. After being placed on assisted outpatient treatment, there were significant reductions in many of the behaviors that we seek to eliminate in our clients. Suicidal behavior among AOT participants was reduced by 55%, homelessness by 74%, inpatient psychiatric hospitalization was reduced by 77%. And alcohol use as well as drug use were both almost halved in individuals who were receiving assisted outpatient treatment at the 6-month point of their assisted outpatient treatment. There were also many benefits in terms of individuals' interaction with the criminal justice system. Arrests were decreased by 83%, violence by 47%, as well as threatened violence reduced by 43%, and property destruction was reduced by 46%. Among the benefits of assisted outpatient treatment are cost savings, not to the individual, but to the systems. That is, law enforcement organizations, courts, hospitals, all spend less because individuals are not having as much contact with them. When we look at the cost of inpatient treatment in New York prior to assisted outpatient treatment being put into place, the average cost across all insurances was $215,418 a year. After assisted outpatient treatment was implemented, those costs had dropped to $127,430, a savings of, in today's dollars, about $100,000. And when we look specifically at the cost to Medicaid, which is most critical to those of us who work with community mental health, the average cost for hospitalization prior to assisted outpatient treatment was $100,000 in urban environments, $71,000 in suburban areas. But after AOT, the numbers had dropped to $69,783 in urban environments and $27,307 in suburban environments. Almost a 50% savings in urban areas and almost 2/3 cheaper for suburban environments. And when we look at the cost per person, in urban environments, it was about $5,239 a year, again, an adjusted amount from 2005. A little bit more expensive in suburban areas at $6,200 and change. These numbers reflect the cost of things like placing somebody on an ACT team, enhanced testing for adherence to substance use treatment, for example. But the average overall savings was between 47 and 58%, depending on the environment they were in. These are huge savings, not just recognized by the entire system, as we saw on the last slide, but these are savings that are going to end up being saved by the actual community mental health providers themselves. Now, as another explanation for why assisted outpatient treatment could be a valuable tool, one of the additional benefits is that it protects you and it protects your organization. We know that one of the best ways overall to protect ourselves and our organization is to utilize evidence-based practices. And all of the services available via assisted outpatient treatment have solid empirical support. So we reduce the likelihood of malpractice because when we use evidence-based practices, we satisfy the legal requirements for competent and reasonable practice, safeguarding ourselves and our organization. We do a better job of self-care actually by utilizing evidence-based practice because it helps us to prevent burnout by giving us the peace of mind that we're doing everything possible. And the final point, and this is a big piece, is that it helps to restore our humanity. When we utilize evidence-based practices, it gives our clients the best chance of a meaningful existence. And that helps us stay focused on the possibilities that exist for our clients, as opposed to sometimes getting stuck in the struggles, the feelings of inadequacy and frustration that comes from working with a very challenging population. Instead of getting focused only on the present problems, we have a way forward. We can see a possible future for the clients that we care so much about. Now, one thing that we need to talk about is assisted outpatient treatment versus guardianship, because depending on the individual, one might be more appropriate than the other. When considering whether guardianship is most appropriate, what should be true about a client is that they are unlikely, even with treatment, to be able to make sound, independent decisions. They should have a limited history of autonomously functioning, and they should have medication allergies, contraindications, or a treatment-resistant condition. So major depressive disorder that just doesn't respond to any of the known treatments. For individuals with these features, guardianship is probably more appropriate. If the individual is likely with treatment to be able to make sound, independent decisions, if they have some history of autonomously functioning, and if medications aren't contraindicated, and even more importantly, if there's been some prior success with medications, then AOT is a great place to start. In fact, for many individuals who get placed on a guardianship order, assisted outpatient treatment may have been a better place to start to more fully evaluate whether they were going to be able to maintain and attain a level of independence that we assume is not present for somebody receiving guardianship. And when we look at what a guardian is responsible for, we can think about how assisted outpatient treatment helps to mandate some of these same things. I should also point out that having a guardian does not exclude somebody from also being placed on an assisted outpatient treatment order. The first step in determining whether AOT is right for your client is to consider what we know about who makes the best candidate for assisted outpatient treatment. And what researchers have found is that assisted outpatient treatment tends to work best for individuals who are younger versus older. A lot of this is because as somebody gets older, we know that there are challenges from health conditions, from prior medications that maybe weren't properly adhered to, and behavior patterns that might have been learned, which aren't necessarily going to respond in the same way to certain treatments. There's also a lot of emerging evidence that younger individuals may benefit from assisted outpatient treatment more than anybody else if it occurs shortly after the onset of a serious mental illness. We know that in the first 18 months or so after the emergence of a serious mental illness, the type of treatment the individual receives during that window has a lot of predictive power on their overall trajectory. AOT also tends to work best for individuals who are living with a psychotic disorder. For example, schizophrenia, schizoaffective disorder. And this is largely because they're able to use long-acting injectable medications that take the whole daily compliance piece out of the equation and help them become more stable for more of the time. Additionally, individuals who experience anosognosia respond very favorably to assisted outpatient treatment. And you've probably encountered times where your clients have started with their medication again and suddenly do have the insight they need to make better decisions, to have a more full life. Additionally, AOT tends to work best for those individuals who do not have any drug allergies to antipsychotics, specifically those that are available in the long-acting injectable formularies. And finally, it works best for those individuals who have the life skills to sustain housing and employment. And part of what you might want to think about are how many of your clients living with a serious mental illness had the onset of their symptoms in their mid-20s, and prior to the onset of their symptoms had been doing quite well, had been autonomous, independent, pursuing career, possibly in school, and then everything changed as a result of the symptoms of their illness. Well, those individuals are especially likely to respond well to assisted outpatient treatment. Initiating an order for assisted outpatient treatment. The general process to obtain an order for assisted outpatient treatment is as follows. First, an adult, and that is anyone over the age of 18, files a petition with the probate court. This is the same form PCM 201 that you use for involuntary hospitalization. The form has been combined, and on this form, you're going to request either AOT only or a combination of AOT and hospitalization, depending on the current situation with your client. Once this is filed, the probate court reviews the petition and schedules a hearing within 28 days. For emergency situations where hospitalization is not requested, an order for transport and examination can be issued so that law enforcement can take the individual into protective custody for a 24-hour period of evaluation. Next, a psychiatrist is going to evaluate the patient and determine if AOT is appropriate. After this, a report testimony is going to be provided to court, and the treatment plan will be filed with the court. There are different ways this can be done, and I encourage you to look at the courts section of this website to gain more nuanced information about this process. Finally, if the court feels there's compelling evidence, an initial assisted outpatient treatment order is issued for up to a maximum of 180 days. This order can be renewed. Thank you for taking the time to review this information. On our website, you can post any additional questions or feedback that would be helpful. And we do our best to keep our frequently asked questions regularly updated so that we can provide you with the most current information to help you do your job. Thank you for your time. This training is presented as a part of the Michigan Assisted Outpatient Treatment Toolkit. To learn more, visit behaviorhealthjustice.wayne.edu/AOT.